what the city's plans are moving forward to ensure the safety of our neighbors who are experiencing homelessness in the city during this time. Before we move further into the presentation and hand over to Molly, I just want to acknowledge that I know this has been a very difficult week for a lot of us, and the murder of George Floyd is heavy on our hearts and minds, and we just want to acknowledge that and express our solidarity with those of you working in the community, the protesters, and everyone who is fighting for racial justice and equity. We at the consortium are doing a lot of reflection, and we'll be working hard to address the systemic racism within our industries, the sectors that we serve, understanding that people experiencing homelessness are disproportionately Black and brown, and that's unacceptable. So we just want to acknowledge that and express our solidarity with our Black colleagues and all of you, doing this justice work on the ground. To move into the logistics of our session, we just want to let you know that it will be recorded and posted on our website along with our previous town hall Q&As, and the slides shared by Molly will also be posted on the website for you. You're welcome to submit your questions into the Q&A throughout the session. Molly will speak for about 15 or 20 minutes, and then we'll open it up for Q&A. So please, enter those questions in. Many of you sent questions to us in advance, and we'll start with those and then move into questions submitted through the Q&A box through Zoom. I think that is all the logistics. Oh, I just want to thank everyone that contributed to organizing this event, our colleagues at the Brooklyn Health and Housing Consortium, please, we will have an evaluation at the end of the session, and we really encourage you to complete that because it gives us feedback on how we're organizing and administering these town halls, and it's also an opportunity for you to let us know which topics we should be covering, who else we should be talking to in order to make sure that you get the information that you need. We really want to be responsive. This town hall topic came out of interest that we were hearing on the ground, so we really do respond to what you tell us would be helpful. So please do complete that evaluation. It'll be shared. The link will be shared in the chat box or in the Q&A later, and it'll also be emailed out to you. All right, with that, I will introduce our speaker, Molly Park. So Molly is part of the senior leadership team at the Department of Homeless Services, overseeing agency operations and implementing the Turning the Tide plan, which includes the creation of 90 new homeless shelters across New York City. Prior to joining DHS in September 2019, Molly spent 3 years as the Deputy Commissioner for Development at the Department of Housing Preservation and Development, where she had primary responsibility for housing production goals of the Housing New York Plan and related pre-development work. Molly also served as the Chief Operating Officer of Settlement House Funding, where she expanded her affordable housing expertise by overseeing settlements, development activity, and coordinating all operational needs of a growing not-for-profit organization. From 2010 to 2014, Molly served as HPD's Deputy Commissioner of Budget, Fiscal, and Performance Management, including oversight of the nation's largest Section 8 programs. So we are very fortunate to have Molly with us today, and I'll hand it over to you. Thank you.
Thank you so much for having me. I'm really pleased to be here. Before I start, I do want to take a moment to acknowledge the 86 DHS clients who have passed away from COVID, as well as the really countless people who have passed away as a result of police brutality and institutionalized racism. So there is so much work to be done. It is a heartbreaking time to be a New Yorker, to be an American, and thank you to all of you really on the front lines who are addressing those. So on that note, I'm gonna move in and talk about how DHS approached the challenge that it was and is COVID-19 response. Just jump to the next slide. So we really started recognizing that this was going to be an issue in late February, and recognizing that managing a deeply infectious disease in a setting where many people are in congregate settings was going to be very challenging. We started really by issuing guidance, helping providers think about how they could adapt, how they could change their shelter operations, and how they could communicate with clients. I am guessing that many of you have been on the emails that we've sent, and we have updated regularly. I'm sure it was very frustrating at the point in time where, you know, the guidance we would release on a Tuesday was obsolete by Thursday, but we really were working very hard to keep up with that. Starting the beginning of March, or middle of March, sorry, we opened our first isolation site. That was a very small one of just 20 beds, but at the peak of the New York City infections, DHS had 5 isolation sites with more than 700 beds. The really terrific news is that as of yesterday, our isolation census was 96 people. We're really very pleased that we seem to be on the far side of that arc of the illness. We are maintaining our capacity to be able to isolate those who are symptomatic, because as I'm going to talk about a little bit later, we are ramping up proactive testing, which we do anticipate will identify more people who test positive despite being asymptomatic. Those isolation sites are all located in commercial hotels. They have a shelter provider, generally somebody who has operated emergency shelter in the past, and 24/7 nursing staff. The sites are really designed to be a place where people recover from COVID. So the emphasis is on wellness checks, the medical care. They are much lighter touch with respect to the other social services that we would typically have in a DHS program. And then early in April, we began proactive efforts to reduce density in our congregate settings. We started with clients 70 years old and older, eventually reduced that down to 65 and older. So we have 4 hotels serving exclusively seniors. And then we moved into de-densifying the entire congregate system. I'm going to talk about this in a lot more detail in a minute, so we'll pause there. Go to the next slide. None of the work that we've done to address COVID could be done without collaborating very closely with our shelter providers. Our providers are our most important partners in working through all of the issues that we have to serve client needs. You know, I mentioned that we have invested a lot of time and energy in making sure that we are providing regular communication with up-to-date guidance. This has ranged from everything on how to clean appropriately for COVID, how to implement social distancing within a shelter. We put together process flows. If you have a client who is positive, then what, and then what, and then what? Communicating about how people get into isolation, and then frankly how people come out of isolation. Really trying to make sure that we, as soon as we have information, that we are communicating it out to our providers. And really also thinking a lot about, we heard a lot very early on from providers about their concerns about financial stability. So we were part of the citywide efforts really led by the Mayor's Office of Contracts to think about what providers' needs were in the era of COVID. So making sure that they had a way to account for and bill us for unusual costs, right? All the cleaning that I mentioned a moment ago, that costs money, as does, you know, there were buying masks for clients, investing in PPEs, you know, thinking differently about how people use transportation. There are certainly any number of ways that our providers incurred unusual costs. And then the city was able to implement a number of changes in process to make sure that we were sustaining provider cash flows. And also, I think this was one that a lot of the people in the nonprofit sector fought very hard for, to make sure that there was some incremental pay for frontline staff who were really, you know, performing absolutely essential duties, you know, during the peak of the crisis and ongoing. and making sure that we were recognizing them for the work that they were doing. Next slide. So a lot for the early days and weeks of the crisis, I think one of the biggest issues that DHS, as so many other institutions, faced was challenges surrounding personal protective equipment, or PPE. This is in the space of things that were not in my area of expertise a few months ago, and now I feel like I know a lot about. PPE is definitely in that category. We were able to do our first distribution of surgical masks the first weekend in March. So we were really out early, making sure that clients had some amount of PPE. But like so much of the rest of the country, we really did face significant supply chain issues. So we were absolutely not able to meet all of the needs. But I'm very pleased to say at this point that supplies have become available. We've distributed, I think at this point, fairly close to 1 million masks or face coverings. We've given out hand sanitizers, gloves. And we are at this point able to do once a month deliveries of provision of supplies to providers, making sure that they have enough equipment to get them through for the next month. It's not just for clients, for staff, it's also for clients. And we're trying to be really thoughtful about building a stock of PPE so that if we do find ourselves back in a place where we have supply chain issues, that we can address them. In the isolation sites where people are known to be ill, we have actually provided a higher level of PPE equipment. So in addition to the surgical masks and gloves, we're giving gowns, face shields, and N95 masks, so that we're really making sure that both clients and staff is safe has been a very high priority. And as soon as we were able to work through the supply chain issues, we were able to do that. Next slide. So one of the biggest initiatives that we have done since the pandemic really hit New York City is focusing on reducing density in congregate shelters. As I assume many people in this audience know, single adult shelters generally have dorms of anywhere from 6 to 12 people, sometimes a little bit smaller, sometimes a little bit bigger. Obviously, that is a challenging place to be able to maintain social distancing, and certainly can't keep people isolated in that setting. So we've been using commercial hotels in a very large scale kind of way to move people out of congregate settings and into these smaller density environments. I mentioned earlier, we started with those who are 70 plus years old, adjusting that down to 65. So we have 4 sites right now that are exclusively serving seniors in commercial hotels. And then once we finished that, we started really actually moving shelters as shelters into commercial hotels. This is unlike the isolation sites, which particularly serve those who are sick, either tested positive and or symptomatic. The density reduction is about protecting people's health and moving those who, as far as we know, are not sick. We are doing at this point about 1,500 people a week. We started with some of the biggest shelters, the shelters with the largest dorms where there had been multiple cases. But we are well on our way to being finished at this point. We have 11,000 single adult clients out of the total population of about 17,000 are in commercial hotels, and we think we'll be finished by about the middle of June. There will be a small number of people who are left in shelters, but those shelters will be substantially less dense. The reasons why we might leave somebody in shelter is because they have a particular constellation of needs that are better served in a congregate setting, but a congregate setting where we can achieve social distancing. Next slide. And just to expand a little bit on the way we've done this density reduction, there's really 3 models. In some cases, we have taken a shelter and moved it into a hotel. All staff, all the clients relocated into the hotel. As I mentioned, in some cases, one shelter is partially relocated into a hotel. We split the staff a little bit, and So we have some clients in the hotel and some remaining in the shelter. And then in a few places, we have done multiple shelters with a common provider relocated into a single hotel. And that has allowed the provider to be able to better operate in what is frankly a challenging environment, but because they can, by co-locating multiple programs within a system, it allows them to share staff. Operating a shelter in a hotel takes more people than it does to operate a shelter operate a shelter in a shelter. The buildings are laid out very differently. It's really important that we're doing, regular door knocks and wellness checks that aren't necessarily the same kind of requirement when you do have people in a congregate setting with dorm mates. So we have, for each shelter that we have moved into a hotel, we have also been adding to providers' contracts so that they can staff up and appropriately operate shelters within hotels. Next slide. So everything I've talked about thus far has really focused on the shelter system, but also want to talk about how we are serving clients who are unsheltered, experiencing either street or subway homelessness. This was also something that we started very early on. Beginning March 9th, we trained all of our outreach teams in screening questions, asking clients that they encountered during outreach work whether or not they had a new cough, a fever, had any contact with anybody who had known infection, or early on in those days known travel, and really encouraging those outreach providers to take people to the hospital when necessary, or to isolation units. I absolutely want to emphasize that the isolation program that we've operated has been available to both DHS shelter clients. Previous DHS shelter clients did not need to be in the shelter system the night before you got sick to be able to access isolation, and those who are experiencing unsheltered homelessness. And then starting in the beginning of May, we had to retool our programming again when the MTA announced that they were shutting the subways down overnight. So we have DHS staff and outreach providers on hand at approximately 30 end-of-line subway stations every night. That number does vary a little bit, based on the activity that we're seeing. We will, if a station is quiet for a few nights, we'll redirect staff. The goal there is to engage the unsheltered individuals who are coming off of the subways and encouraging them to accept services and to come indoors. A couple of innovations that we've put in place to adapt to the higher demand that we're seeing as a result of the subway shutdown. One is we created an expedited intake process so that our outreach workers can do shelter intake over the phone with a client from the subway platform or from the street. So it eliminates the need to bring somebody into the 30th Street Intake Center. They can go directly to the appropriate placement. We've also been significantly expanding the number of safe haven and stabilization beds that we have available to make sure that we have the appropriate placements for people who are coming off of the street. We have a plan to add more than 1,000 safe haven and stabilization beds, with about 700 of them already online. Next slide. So, excuse me, the question that everybody asks, providers ask, my staff ask, more or less, our oversight agencies ask is what's next, and when does the system reopen, and when does it look like it did before? I don't actually know the answer to that. I think, there's a couple of things that I can talk about that I can say for how we are looking forward. One is, like the rest of the city, we are really thinking about and investing in and standing up a significant testing program. We think it is important that we are doing proactive testing across all of our congregate shelters. Right now, we're working with our partners, particularly the sites that have on-site medical providers, to test somewhere around 500 people a week. We issued an RFP to bring on medical providers and significantly ramp up the pace. That is on track. And we are offering voluntary testing to all the people in the congregate system that will be used to move people to isolation who who test positive but who are asymptomatic. So we think that is going to slow the spread of the illness within the shelter system, but it's also going to inform how we think about bringing people back. Right now, people are staying in the hotels. We are not moving people back to congregate settings. We do not have a formal date for when we're going to move people back to congregate settings. We are coordinating very closely with the health agencies, and we expect that we will align with the governor's phased approach to reopening and land somewhere in the late phase 2, phase 3 side of things. But that is something that we're assessing on more or less a daily basis. I think if it proves that if there's things that we learn from testing that mean we could do that a little bit faster, maybe there's some opportunity to do that. On the flip side, we may learn things that mean that we have to go slower. So I think a lot of providers, a lot of clients are anxious to get back to the more traditional settings. There are certainly advantages to being in a shelter setting, but right now we are taking it slow and assessing the public health impacts of any changes. So I just blew through a lot of information fairly quickly. That is my formal presentation, but I really wanted to make sure that I was leaving plenty of time for questions.
Great, thank you so much, Molly. So we've been having some questions come in, and we're trying to organize them a bit by topic so we can kind of go through topic by topic. So first, what is the current COVID-19 screening protocol at DHS shelters?
Sure. So we have nurses at the intake and assessment centers who are taking temperatures, and all of our DHS and shelter staff are trained to ask the screening questions about, do you have a new cough? Do you have a fever? Have you lost your sense of smell or taste? And that when anybody who answers yes to those questions, the expectation is that people will be transported to an isolation bed. As I mentioned early on, we have plenty of isolation capacity. So, it is not a requirement to get tested to come into shelter. We are a right to shelter city, and I don't expect that it will be a requirement to be tested to come into shelter, but we are working very closely with shelter staff to make sure and encouraging clients to self-report conditions, so staff are asking, clients are self-reporting, and people are going to isolation when needed.
Great. How are the homeless shelters dealing with individuals who are COVID-19 symptomatic and those who are positive?
Sure. So that's where the isolation sites come into play. Anybody who is symptomatic or test positive goes to an isolation site, which is as I mentioned earlier, one of these now 4 commercial hotels that have a provider and 24-hour medical staff. The expectation, excuse me, is that a client will stay there for 14 days from the point of their onset of symptoms. That is the current State Department of Health guidance for when somebody can go back to a congregate setting. It's 14 days since onset of symptoms and 3 days without a fever. At that point, once a client reaches that stage, the DHS medical director's office will review their health history for the last couple of weeks and decide whether or not they are able to return back to their shelter. That's what we're doing for single adults. For families with children who are largely in apartment style units, most of them are isolating in place in their unit. If a family has a family member who's immunocompromised, or there's some other reason why somebody who's ill cannot stay in the unit, they are also able to go to isolation.
And what services are being offered in isolation shelters?
Sure. The emphasis there is really on medical services. The isolation sites are a place for people to recover and to heal. They are not long-term shelters. So we have 24-hour nursing care who is doing, wellness checks and can do some help with some medication management, who can escalate, identify if somebody's health condition is deteriorating, escalate as needed. We have people linked to telemental health services because it can be very challenging to be isolated in a hotel room. We have arranged, working with our partners at the City Department of Health and the State Health Department, methadone delivery for people who need it, who are in isolation sites. But the theme that you'll hear running through here is really about medical care and helping people recover from COVID, and then they will return back to their shelter for independent living planning, housing assistance, employment counseling, those kinds of services.
A question about that feels very important right now is the role of the NYPD in with the subway closures and in accompanying an outreach for moving people off of the trains at night. Given what we know about police violence and the fact that, again, homeless people, people experiencing homelessness are largely Black and Latinx. Can you talk a bit about how the city and DHS are planning to protect homeless New Yorkers who of color who are going to be interacting with the NYPD right now?
Sure. So we do partner with the NYPD on our outreach efforts, but I also do really want to emphasize that this is a DHS-led initiative. DHS holds the contracts with the nonprofit outreach providers. DHS is providing very large numbers of staff who are out at every site on a nightly basis. And DHS is really setting the tone. Whether it's our outreach work or our in-shelter work, the philosophy of DHS is that every client has strengths, that we need to provide client-centered services that recognize and build upon those strengths, and that just based on the experiencing homelessness is in itself a form of trauma, and that we need to be providing trauma-informed care. That is the lens that we approach all of our work, including our street outreach work. And we work very hard with our police partners to make sure that they are trained in that perspective and that we are setting the tone. We generally think it is positive that the police department is interested in working with us on client-oriented work, that the police department has hired nurses, for example, we think is a positive step. But it is also really important to us that we are the lead in whether it is contracting or providing the housing options at the back end or the day-to-day client interactions.
Thank you. Along the topic of subway closures, are those still happening even during curfews and protests? And what is DHS doing to protect people on the streets, many who may not be coming from end-of-line subway stations where outreach workers are?
Yes, the subway closures are still happening. Actually, let me rephrase that, because this is all happening very much in real time. The subway closures happened last night. I have every expectation that they will happen tonight, and I have no information to suggest that they won't continue through the curfew. That being said, things are changing obviously very, very rapidly, and we are adapting along with it. We have had DHS staff and provider staff were out there last night. We spent a lot of time today talking about what was the best option for both clients and staff, and we will be out there again tonight. We really want to encourage people to be to come inside, and I think we have a really robust array of options that we can offer people at this time, with whether it's stabilization bed, safe haven, shelter, so that we can meet people where they are. I will say that the language of the executive order around the curfews exempts both essential workers and people experiencing street homelessness. So certainly nobody should be arrested for curfew violations because they're experiencing street homelessness.
Another question on this topic. First, there's a thank you for giving the incremental pay to outreach staff and essential staff. Now, given the new focus on the end-of-line subway stations and funneling people into places, is there still room for traditional outreach that allows for taking the time to build rapport and giving clients a bit more self-determination?
Yes, absolutely. We think the relationship development aspect of outreach is really critical. This has been a time of really rapid adaptation, right? The subway closure was announced 4 days, 5 days before it actually went into place, and DHS and the outreach providers were able to have people on the ground that same night. There were, hiccups that first night. There have been fewer hiccups every night since then. I think doing anything that dramatic that quickly means that we sort of almost by definition are having to redirect resources in ways that are maybe less than ideal. But as we go forward, we're going to be able to recalibrate and adjust. We are learning, for example, that not all of the end-of-line stations have the same volume of people. We can maybe redeploy some of the teams, and there will still be the opportunity to do that same very long-term engagement.
Okay, some questions about testing. Is DHS retesting people leaving isolation before sending them back to their assigned shelters?
We are not. We are following the guidance from the health agencies around basing discharge based on history of symptoms for a couple of reasons. One is we've been operating isolation sites far longer than there has actually been readily available testing. So we did need to have practices in place before we were able to roll out testing. But also because the health agencies have determined, and actually the Department of Health just issued some really useful guidance on this, that people can test positive well after they've passed the point of being contagious, because there's virus particles still in their system. So at this point, the Department of Health guidance says if you tested positive, you completed your isolation, your symptoms are no longer active, and you test positive again, you do not need to be re-isolated.
Who is DHS partnering with to conduct the testing? Who did the results go to? For example, are results shared with people's healthcare providers, with DOHMH? Are aggregate results being made public, such as % of residents testing positive at various shelters? That has been done in other cities, including Boston, San Francisco, and Atlanta.
A lot there.
Yeah. So first, who is DHS partnering with to conduct testing?
So right now we are largely partnering with the medical providers who are based at shelter sites. Of our single adult shelters, about a third of them have an on-site medical practitioner of some kind. So it's, whoever that medical provider is taking the lead on the testing, and we're working very closely with them. We are contracting to bring on a provider to do the rest of the sites and to be able to pick up the pace. That's still in the procurement process, so I can't be more specific about that. Results go to DHS staff. If a client signs the waiver allowing that, we think it's important that DHS and the shelter staff know about client results, because we want to make sure that we are linking people appropriately to isolation. But clients are also obviously informed of the results. DOHMH gets everybody's positive results. Anytime a test is done that comes back positive, that gets reported to DOHMH. So, for example, if you were a shelter client who got tested in the hospital, we might actually learn of that via DOHMH. So they are very much deeply involved in the reporting as well. I think, with respect to reporting out results, we're still in the process of sorting that out, how exactly we're going to do that. I think it's valid feedback to want to hear that by shelter. I can say sort of for the universe that we've done so far, we're running about an 8.5% positive rate.
Is there a plan in place for testing of street homeless clients?
We're definitely looking at expanding the testing that we're doing to safe havens, potentially drop-in centers. I think how we would do that for clients who are not connected to any geographic-based service, that needs a little bit more thought, but I think it is a valid suggestion.
And will testing be available to only clients or staff as well?
We're doing staff as well.
Okay. The mayor said that there would be widespread testing in shelters in mid-May. What happened there?
I think what was said was that we would roll it out in mid-May, and we did roll it out in mid-May. I will say, I think there are a lot of complications with rolling out of testing, that we need a provider who is medical staff who are ready to do it. We need lab capacity. We need test kits, and they all have to work together. So there are test kits that use 3D printed swabs. Some labs accept the 3D printed swabs. Not all labs accept the 3D printed swabs. So if you have a provider who is ready to go and they have lab capacity, but we don't have the test kit with the right swab, that is a challenge, right? If you have test kits and lab capacity, but we don't have the medical care to do it, that's a problem, right? So we are working through it. We did absolutely hit the middle of May rollout date, and we are expanding rapidly.
And is there a plan for retesting, repeat testing of clients, and how often will that be done, if so?
That's definitely something that we're still working through with our healthcare partners, in addition to setting up front door testing, to make sure that as people come into the system, we're screening people.
Okay, moving on to questions about the hotels. Is DHS providing shelter providers with help with services in hotels? By providing services across multiple hotels, or universal guidance about services, such as services for mental health or substance use? It strikes me that provider by provider will be very dependent on the capabilities of that provider.
I mean, we are working very closely with them with all of our providers, excuse me, to make sure that folks are staffed adequately for managing the different kind of space, and that includes making sure that people are setting up wellness checks. It is very different to have people in private or semi-private rooms behind a closed door than it is to have them in a dorm room. So we're really encouraging clients to think about that, to make sure that that we're if there needs to be additional telehealth, mental health services, that we're incorporating that. But there is, I don't think there's a one-size-fits-all formula here, because we are dealing with lots of different populations. You might have a general population shelter, employment shelter, mental health, and each of them needs something a little bit different. But absolutely, the DHS staff are working really, really closely with the providers, and we're problem solving and developing programmatic responses as we go.
Is there a sense of how long the 70+ years old clients will be able to remain in the hotel beds they have been offered?
So those, unlike the majority of the hotels that we are working with, the majority of that we've used for de-densification, are hotels that were never part of the DHS portfolio to begin with. Some cases, these are, quite luxurious buildings. They, things that would not have been normally used for serving homeless clients. That came out sounding not exactly how I would like it, but we are in many more hotels than we would normally be in. The 4 hotels that we are serving with seniors were actually buildings that were already in the DHS portfolio. So we have longer term relationships and contracts with those. So those are places where I think where it's going to be a much longer runway before people go back to home shelters, if they go back to home shelters. I think with seniors in particular, there are real pros and cons with having folks in hotels. On the one hand, right, it is private and semi-private rooms are a good way to keep vulnerable people safer from COVID. On the other hand, hotel rooms almost all have, for example, step-in bathtubs, right? They're not necessarily set up for a senior population. So we're, working with providers, working with the health experts to really keep an eye on how the cost benefit analysis or the different kinds of balancing the different kinds of risks that are associated with having people in hotels. Right now, the calculation comes firmly down on we are protecting public health by having people in hotels. But as the arc of the virus changes, the downsides of hotel use will at some point tilt us in the other direction, and we will reassess.
What will it look like when these isolation hotel beds are taken away from people currently living in them who either did not have shelter beds before or will refuse to return to shelters?
Right. So let me take a step back and clarify when we're talking about the isolation sites, that is for hotels that are specifically serving people who are either COVID positive and or symptomatic. Most of those are people who are coming out of congregate shelters into isolation. It does also include some people who are experiencing street homelessness or people who've come from other systems. For example, people who were released from Rikers who self-identified as experiencing homelessness and who were COVID positive came to our isolation sites. If somebody, and they are staying for, in most cases, 14 days, a little bit long, in some cases a little bit longer if their symptoms last longer. If they came from the shelter system, we are saving the bed in their assigned shelter. If they did not come directly from the shelter system, we will match them with an appropriate bed elsewhere in the system. And we really haven't had an issue of people staying longer than their assigned isolation time.
Is there any conversation with hotels about partial conversion to permanent or long-term transitional housing, similar to conversion of cluster sites for families?
I think this is an incredibly interesting idea. It's absolutely something that we're talking about and thinking about. There are a lot of variables about whether or not a site is appropriate for conversion, starting with the zoning. If it isn't zoned residential, it's going to be much harder to use for permanent housing. It might require a ULURP, which is not a fast process. The physical configuration, whether or not there's kitchens in the units, for example, or is it going to require substantial rehab to put kitchens in units? Can the piping and other kinds of building systems support kitchens? And then we also have to think about price and what real estate prices look like. Right now we are doing everything that we have to do to protect client and staff health. But I think at the end of the day, we also have to recognize that we're facing a really challenging city budget situation. So we have to make sure that we are balancing that interest.
What if someone is too vulnerable to return to shelter due to age, current chronic conditions or needs?
Yeah. This is something that we in the DHS system wrestle with all the time, pre-COVID and ongoing. People who have needs beyond what we can reasonably serve within shelter. And I think DHS's Office of Medical Director works really closely with the hospital system, with trying to facilitate other forms of placement. In the COVID context, we've been working really closely with H&H to make sure that if somebody, isn't appropriate for one of our isolation sites, that they're getting referred to one of the alternative care centers. We are, connecting people to nursing homes when that's the appropriate thing, but really thinking on an individual basis about what a client's needs are. It is not good for anybody, for the client or for DHS, for somebody who is with significant medical needs to be in our system. So we really work very hard to try and support them.
For the hotel occupancy, has DHS considered purpose-altered sheltering to use for longer-term sheltering, especially in anticipation of a second COVID wave in the fall or winter? How can architects or engineers assist in this effort?
Fabulous question that I think we are just at the early stages of thinking about. There was no blueprint for how to adapt congregate shelters to be safe in a pandemic, right? That didn't exist. Moving people into vacant hotel rooms was a way to very quickly act to protect people's health. It is not a long-term solution, and I think we're going to have very serious conversations about what congregate shelters look like going forward. And I think architects and engineers, as well as service providers and clients and healthcare professionals, all need to be a part of that conversation.
What makes a client ineligible for the social distancing hotels? Clients who do not have COVID symptoms.
This is sort of an art, not science, but if we have an individual who has really either significant physical or behavioral health needs that might be exacerbated behind a closed door, DHS staff in consultation with the provider might decide that that individual is better served in a de-densified congregate setting. One relatively straightforward example, most hotels only have a handful of rooms that are ADA compliant. We have some shelters that have, half or more of their client base that have mobility needs, right? So leaving those clients in the shelter while we de-densify, but having it be de-densified, right? Making sure that there is at least 6 feet between beds and taking other precautions is a way to do it. If we have a client who is an active substance user, and there are real health concerns about having that person in a private room, that might be another reason why the balance of risk feels a little bit different for that client, but it's a very individual decision.
Can you provide clarity on asymptomatic positive after the 14-day isolation? Are they then considered safe from spreading the virus? Obviously, this doesn't only apply to the homeless population, though in this case it does.
Okay. I'm going to do my best with the giant caveat that I am not a doctor, and there is Department of Health guidance up on their website, which we can forward around afterwards. So my understanding is that after a period of time that the virus in your system breaks apart, but there can be pieces of it still in your system such that you would test positive after the point that you are no longer contagious. But according to both CDC and the Department of Health, if after 14 days from onset of symptoms, you are feeling better and have not been feverish for 3 days, you are safe to leave isolation.
Why did it take a pandemic to eliminate the intake requirement for people living on the street and allow direct placements in program shelters? Will DHS continue with this going forward after the pandemic lets up?
So I do want to clarify that we are still doing intake. We're doing remote intake. I think it's a useful innovation, and it's something that we're definitely going to consider how we can keep it's how we continue to use it. You know, the DHS system on any given night is a really dynamic and rapidly changing system. We are linking people to beds in real time, and being able to, you know, interact with the person and assess what their needs are and help them get to that right placement is, there is value to that, but we also understood in this environment that there was value to keeping people out of 30th Street, and I think it is something that we will assess how we can continue.
A number of my clients are street homeless and live in encampments. They have been routinely threatened by the NYPD and DHS that they would lose their belongings or arrested if they don't leave. There are many other cases of NYPD and DHS breaking up encampments because of the increased risk of catching COVID. My clients have SMI and have been attacked at DHS shelters, specifically 30th Street. How can DHS bridge that gap to those individuals who are unwilling to go to shelter, besides the already mentioned outreach teams?
I think let me start by saying that, you know, we try very hard and you know, happy to talk offline about individual circumstances, but that cleanings should be happening when there is sort of large collections of stuff on the sidewalk, where we do need to balance the real needs of people experiencing street homelessness, but also with the needs of the larger community. So I do want to say that, and I'm happy to talk about particular circumstances offline if you want to get in touch with me. With respect to meeting clients' needs, I think one of the things that we're doing that's really important is making sure that we are investing in a range of different sheltering and housing options. So traditional shelter remains a really important tool. I think it's a really service-rich environment, and a way to connect people to permanent housing and long-term stability. We are also investing, though, in expanding our safe haven portfolio. This was something that was in process even before COVID, as part of the Journey Home. There was a commitment there to add 1,000 units of safe haven beds, and that we've been continuing to invest in that development throughout the last several months. And then, as I mentioned, we're really adding stabilization beds as well, which are you know, faster and easier to bring online because they don't have the same long-term contract. They don't have the same sort of construction generally associated with them. So in fact, we're even doing some stabilization beds in commercial hotels at this point. And that provides a much lower threshold, also lower services, but lower threshold setting for clients that is appropriate for meeting some people's needs.
We have 2 minutes left, so I'm going to kind of put two questions together. Have the requirements for shelter eligibility changed due to COVID? And is there a specific plan for clients staying in church beds?
No changes in eligibility at all. There has been, on the family side, which is where eligibility actually occurs, there is no eligibility screening for single adults. There have been some streamlining of paperwork requirements and processes to try and limit the amount of in-person contact that happens as part of the eligibility review. But no, there haven't been any changes in eligibility. And sorry, the second question.
A specific plan for clients in church beds.
Oh, most of the church beds have closed during COVID. You know, these are volunteer-driven programs, and they made that decision to close fairly early on. I think what we've seen is an uptick in clients who are coming into our system, into the stabilization beds, into shelter, into the variety of different options who might have otherwise been in church beds. Although, since those are not programs that have the same kind of, you know, registering of clients and connecting information to us, it's a little hard to say definitively client to client.
Okay, let's see. Maybe we have time for one last question. Can you speak a bit more about the process of completing the shelter intake over the phone? Is that a matter of simply calling 311 to reach outreach workers? Who can do that?
The outreach workers can connect directly to the 30th Street intake. So this isn't something that an individual does on their own, but it's a way that the outreach workers can facilitate the process with the intake staff to make sure that that clients are coming into the system and being linked efficiently to beds in whatever the most appropriate setting is.
Okay, well, it is 4 o'clock. Molly, thank you so much for your time and sharing all this wonderful and thorough information. We did have some questions that we weren't able to get to. Would it be okay if we sent those your way, and maybe you could send us some responses back that we can share?
Absolutely, happy to do that.
Okay, that would be great. Thank you to everyone who joined and asked questions. I'm sorry if we weren't able to get to your question live, but as we just confirmed, Molly will be able to get us those answers to you soon. This session, as I mentioned, is being recorded, and we'll post it on our website and share that link with all of you, as well as the presentation. I just want to thank everyone that helped organize this, from the Bronx and Brooklyn Health and Housing Consortia, and on the side of the Department of Homeless Services. Molly, thank you so much for your time.
Thanks for having me.
And to all of you, thank you for doing this work. And I know these are incredibly difficult times and you are under enormous pressure. So I hope that this information was helpful to you. Again, please do complete that evaluation to let us know what else would be helpful, and stay safe. And thank you. Take care, everyone.
Thank you, Molly.
Thank you.